This is Randy Schell, and I'm making a video cast entitled Physiologic Effects of Inhaled Anesthetics. It's foundational information about the physiologic effects of inhaled anesthetics prior to a flipped classroom interactive discussion. Let's first look at the American Board of Anesthesia in-training exam keywords between 2007 and 2017 related to this topic, physiologic effects of volatile anesthetics. Can divide them into the major organ systems, the central nervous system first. The volatile anesthetics, their effect on cerebral metabolism, that is a reduction. Their effect on cerebral blood flow, an increase. And their effect on monitoring, such as SSEP or motor evoked potential monitoring, where they have an effect of increasing latency, decreasing amplitude, and making motor evoked potential monitoring very difficult. The cardiovascular system, the effects of desflurane, of activating the sympathetic nervous system, raising norepinephrine levels, especially when its volatile anesthetic concentration is increased rapidly. The respiratory effects of volatile anesthetics, including that they are all bronchodilators, that they impair the ventilatory response to hypoxia, and they have many other respiratory effects which we will touch on. And the fact that volatile anesthetics relax muscles and potentiate both depolarizing and non-depolarizing neuromuscular blockade. So let's look at the central nervous system first, where volatile anesthetics reduce cerebral metabolism for oxygen. The oxygen requirements go down as the volatile anesthetic concentration goes up. And as cerebral metabolism goes down, the EEG activity tends to go towards lower frequency, higher amplitude, and eventually to burst suppression, and finally to full suppression at usually greater than 2 MAC concentrations of volatile anesthetic. The volatile anesthetics are cerebral vasodilators. Just like they vasodilate the systemic circulation and reduce blood pressure, they dilate the cerebral vasculature and actually increase cerebral blood flow in a dose-related manner. So you can see here, metabolism is going down, but cerebral blood flow is going in the opposite direction of increasing. If cerebral blood flow goes up, under some circumstances, intracranial pressure can increase. For example, if you had a patient with a tight head, cerebral edema, cerebral bleed, or something like that, whose CO2 was increased in their blood pressure was up, and they were under a volatile anesthetic, all those conditions could result in an increase in intracranial pressure. But note that inhaled anesthetics don't abolish the cerebral vascular responsiveness to changes in arterial CO2, such that if you hyperventilate a patient, drop their arterial CO2, that will decrease cerebral blood flow even in the presence of a volatile anesthetic. Now, volatile anesthetics are associated with postoperative cognitive decline, and there's lots of discussion going on now about the elderly and the very young and the effects of inhaled volatile anesthetics on their neurologic postoperative function. Neuromonitoring, the volatile anesthetics have a dose-dependent effect on the electroencephalogram. And at the top right is a figure showing the effects of volatile anesthetics at different concentrations on the EEG. Let's look at the awake state first, where there's relatively high frequency and your BIS would be reading close to 100. As the patient is sedated, the BIS drops, in this example, down to 80, and you can see higher amplitude, lower frequency waves. And then at surgical depth anesthesia, at that magical BIS numbers of 40 to 60, you can see the high amplitude, low frequency heading towards the delta theta waves rather than the alpha beta waves, which are higher frequency. And then as the volatile anesthetic increases even more, burst suppression, very low BIS numbers, and eventually isoelectricity, where the BIS is 0. The volatile anesthetics decrease the amplitude and increase the latency of SSEP signals, or somatosensory evoked potential signals. For example, if you're monitoring SSEPs and MEPs during major back surgery, you are looking at the amplitude, the height of the signal that's coming through, and how long it takes to get through, which is latency. And the volatile anesthetics are going to make the height of that signal lower and the time that it takes to get through, or latency, longer. So it makes it more difficult to monitor SSEPs under very high concentrations of volatile anesthetics. Doesn't mean that you can't use volatile anesthetics with SSEP monitoring alone, and in fact, if you use less than 1 MAC concentration, you can monitor SSEPs usually quite effectively. However, if you're monitoring SSEPs and MEPs, remember that SSEPs monitor the posterior part of the spinal cord, while the MEPs monitor the anterior part of the spinal cord. The MEPs are very sensitive to depression by the volatile anesthetics, and it becomes near impossible. So a TIVA-based anesthetic is usually used when SSEP and MEP are combined in neuromonitoring. What about the cardiovascular system? If you look at the y-axis, the mean arterial blood pressure is represented, and the x-axis is MAC. And you can see that with increasing a MAC delivered of a volatile anesthetic, the mean arterial pressure decreases. And it does so similarly between all the volatile anesthetics, such that you cannot tell the difference between SIVO, DES, or ISO, for example, their decrease in mean arterial pressure. And they do so by vasodilating. And that is represented in the next graphic that says, okay, if mean arterial pressure decreases, does it do so by affecting cardiac output, flow, or systemic vascular resistance, realizing that mean arterial pressure equals a flow times a resistance, or cardiac output times SVR. So if you look at the graphic on the far left, with cardiac index on the y-axis and MAC on the x-axis, you can see that in general, cardiac index is preserved, excluding halothane, which is mainly shown here for historical benefits. On the far right, you can see systemic vascular resistance on the y-axis and increasing MAC concentrations. And in general, you can see that there is a decrease in systemic vascular resistance with increased amount of delivered volatile anesthetic. So simplistically, you can think of our volatile anesthetics as vasodilators that preserve cardiac index. And if you look at heart rate, again excluding halothane shown in the white square, you can see that there is in general a reflex increase in heart rate with the volatile anesthetics, desflurane, isoflurane, and sevoflurane, which you would expect if your blood pressure decreases and you have intact carotid sinus reflex, your heart rate would go up. Desflurane is quite unique, and isoflurane has some similar effects because of their pungency, that is, their upper airway irritability. And if you look at the graphic on the left of heart rate on the y-axis and time on the x-axis, with rapid increased concentrations of desflurane, for example, if you turn your desflurane vaporizer from 0 to 10% at the beginning of an anesthetic, it's not uncommon to see a tachycardia and hypertension result. However, this graphic shows that even small concentrations of fentanyl, 1.5 mics per kilo, so we're talking a couple cc's maybe of fentanyl to a patient, blunts that heart rate response from desflurane quite significantly, and we don't see this very commonly because of that. On the graphic on the right, you can see that this rapid increased change in concentration of desflurane from 0, let's say, up to 10%, results in an increase in norepinephrine levels in the body. And it does so for a period of time of minutes, just like that blood pressure and heart rate effect tends to be for a short period of time of minutes. So when we're introducing desflurane to a patient, it's usually recommended that we do so gradually. For example, increase to 2%, wait 3 to 5 breaths, increase another 2%, etc., if you want to avoid this increase in norepinephrine and the tachycardia. Cardiovascular stimulation is induced by these rapid increases in desflurane and also to some extent by isoflurane. It fatigues, meaning that if you did this repetitively, increasing the concentration and then decreasing it of DES, increasing it and then decreasing it. Eventually, the body says, I know what you're going to do next. And for some reason, it no longer responds with quite the increase in heart rate and norepinephrine levels. So this is a fatigue effect. It's mainly explained by the activation of tracheopulmonary and somewhat systemic receptors because, yes, desflurane irritates the upper airways and can result in this norepinephrine increase. But if you introduce desflurane through a cardiopulmonary bypass circuit directly into the blood, you can see the same effects with rapid changes in concentration. So it's not just tracheopulmonary, there's probably some systemic receptors involved. And this effect of desflurane of stimulating the sympathetic nervous system is attenuated if you give beta blockers, for example, or dexmedetomidine, an alpha-2 agonist, or clonidine, an alpha-2 agonist, or opioids, as previously shown, small doses of fentanyl blunting that effect. And it may be attenuated in neonates and geriatric patients, so you may not see it quite so much in the very young and the very old if you change desflurane concentrations rapidly. Coronary steel, what is that, and is this a problem with volatile anesthetics? The graphic at the far right shows an anatomic situation in which coronary steel could occur. In this case, there is total occlusion of the left anterior descending coronary artery, with some occlusion of the circumflex and collaterals occurring between the circumflex and the distribution of the LAD, such that if a vasodilator was administered that vasodilated, for example, the distribution of the circumflex coronary artery, the ischemic area in the distribution of the LAD is already maximally vasodilated, and blood could be pulled from that ischemic area over to the area that can still vasodilate in the circumflex distribution. That's called coronary steel. And volatile anesthetics are coronary epicardial vasodilators. And there was worry in the past about the potential for coronary steel with volatile anesthetics. However, there's no difference in outcome when patients who are at risk for myocardial ischemia have this steel-prone coronary anatomy, receive inhalational anesthetics, for example, desflurane versus, for example, intravenous sufentanil-based anesthetic. And it doesn't appear to be a major clinical concern under most conditions. What about myocardial sensitization to catecholamines, and what does that mean? The graphic on the far left on the y-axis shows the percentage of patients exhibiting ventricular extrasystoles, or ventricular premature beats, with increasing doses of epinephrine per kilogram of body weight on the x-axis. And you can see historically with halothane, it didn't require very much epinephrine. 2 mics per kilo of epinephrine, and a substantial number of patients were receiving or developing ventricular extrasystoles. And we said that halothane sensitized the heart to catecholamines. You can see that it takes a lot more epinephrine when you're under isoflurane anesthesia, or in the far graphic, desflurane anesthesia. In fact, we're talking up in doses of epinephrine of 5 to 10 mics per kilo. Let's put that into clinical perspective. If you have a regional anesthetic being administered with a 1 to 200,000 of epinephrine added to the local anesthetic, that's 5 mics per kilo, or 5 mics per cc of epinephrine, 1 to 200,000. So let's say you gave 30 cc's of a local anesthetic to a patient. 30 cc's times 5 mics per kilo, that's 150 mics, or approximately 2 mics per kilo body weight. So you can see that in general, when we talk about myocardial sensitization to catecholamines, it was halothane that was the bad actor. It takes a large amount of epinephrine when you're under isoflurane or desflurane anesthesia to cause those ventricular extrasystoles. So we don't talk about myocardial sensitization with desflurane or isoflurane. Inhaled anesthetics in the QT interval. Inhaled anesthetics do prolong the QT interval, as shown on the far right, the QT interval being from the Q wave just before the QRS complex to the end of the T wave. And patients with long QT syndrome are at risk for torsades de pointes or multiform ventricular tachycardia. In these patients with long QT syndrome, we do our best to avoid any medications such as antiemetic medications, many of those which prolong the QT syndrome, prolong the QT interval, droperidol being one of the classic ones. These patients with QT syndrome are treated with beta blockers frequently, and patients with long QT syndrome that are concurrently treated with beta blockers have been safely anesthetized with all modern inhaled volatile anesthetics. So yes, inhaled volatile anesthetics do prolong the QT interval, but can we anesthetize most patients safely with the volatile anesthetics? And the answer seems to be that if they're on beta blockers already, that they can be. Doesn't mean that many people would not administer a TIVA-based anesthetic to these patients, however. Preconditioning, what does that refer to? Well, if you take a patient's heart and expose that heart to multiple brief episodes of ischemia, little periods of ischemia, before a big one, it seems to protect that heart against the amount of injury that occurs when it has a big episode of ischemia. And our volatile anesthetics have a protective effect against myocardial ischemia, and they seem to enhance this ischemic preconditioning. And it seems to do that by affecting mitochondrial ATP-sensitive potassium channels. So do inhaled anesthetics have a protective effect against myocardial ischemia? Yes, they seem to, and they seem to do it via ischemic preconditioning via the mitochondrial ATP-sensitive potassium channels. So let's look at some comparative cardiovascular effects now. In summary, the volatile anesthetics are vasodilators. There is a reflex increase in heart rate, and cardiac index tends to be preserved. If we look at the decrease in mean arterial pressure, isoflurane, desflurane, and sevoflurane at equal MAC concentrations do it quite equally. The sympathetic nervous system tends to be stimulated most by desflurane, somewhat by isoflurane. Dysrhythmias are most common with halothane and much less so with the other modern volatile anesthetics, isoflurane, desflurane, and sevoflurane. Coronary steel doesn't seem to be a significant clinical issue, and preconditioning does occur with volatile anesthetics. Note that when we replace part of the MAC of our delivered anesthetic with nitrous oxide instead of the volatile agent, for example, if we decrease from 1 MAC isoflurane to 0.5 MAC isoflurane and give 0.5 MAC nitrous or 50% nitrous, you're not going to get the same decrease in blood pressure that you would if you delivered your 1 MAC of isoflurane because of the vasodilating effects of isoflurane and the sympathetic stimulating effects of nitrous oxide. Let's switch now to ventilatory effects. What's the usual pattern that you see when someone is breathing a volatile anesthetic? And that is a panting, a low tidal volume, fast respiratory rate, and when someone's breathing through an LMA, that's something that you see consistently. Respiratory rate 25, tidal volume of 200. So alveolar minute ventilation actually goes down because more is going to the dead space. The dead space of normal humans is approximately 1 mil per pound or 2 mils per kilogram. Therefore, approximately 150 mils is anatomic dead space, getting oxygen and air down through the plumbing to the gas exchanging alveoli. And so if the total tidal volume was only 300 mils and 150 of it is dead space, that means 150 over 300, or approximately 50% of it, is going to dead space. So low tidal volume breaths will decrease alveolar minute ventilation, increase the amount that's going to dead space relative to tidal volume. Airway resistance is reduced by all our volatile anesthetics. They're all bronchodilators of the lower airways, and all of them depress the ventilatory response to both carbon dioxide going up and oxygen going down. In other words, if CO2 goes up, normally we'll breathe faster, but the ventilatory anesthetics are going to depress that. And normally, if we become hypoxic, our body will respond with hyperventilation, and that's greatly depressed by the volatile anesthetics. They're altering both central and peripheral chemoreceptor function in a dose-dependent manner. And graphically, this is shown on the next slide here, where sub-MAC, that is only 0.1 MAC concentrations of volatile anesthetics, greatly depress the ventilatory response to hypoxia. In this case, you can see that at least 50% or so or more of the response to acute hypoxia is blocked at only 0.1 MAC concentration. So a profound depression of the hypoxic responsiveness is produced by inhaled anesthetics, suggesting that patients may have diminished ventilatory response to hypoxemia in the recovery room for some time after the agent has been discontinued. Other respiratory effects: the volatile anesthetics inhibit the ciliary function and mucus clearance. There's a small decrease in pulmonary vascular resistance. They're vasodilators of the pulmonary vasculature. Nitrous oxide, conversely, causes a small increase in pulmonary vascular resistance. Hypoxic pulmonary vasoconstriction, or vasoconstriction of blood vessels going past alveoli not containing much oxygen in them, is modestly inhibited by the volatile anesthetics. However, this is a relative minor effect, and it rarely affects our clinical decision making of what anesthetic to choose, for example, in a patient who, for example, is single lung ventilation. Should we use TIVA? Should we use volatile anesthetics? We do know that volatile anesthetics have a small effect on blunting HPV and increasing shunt. What about the neuromuscular effects? Volatile anesthetics cause skeletal muscle relaxation. They do so much more than the intravenous agents and nitrous oxide, such that if you had a desflurane, sevoflurane, or isoflurane-based anesthetic mainly versus, for example, remifentanil or propofol TIVA anesthetic, and you wanted to keep a patient relaxed to one twitch with rocuronium, you would need more rocuronium over a long period of anesthesia to keep that patient paralyzed if they were under a TIVA-based anesthetic versus a volatile anesthetic. Because our volatile anesthetics enhance the activity of non-depolarizing and depolarizing neuromuscular blockade. All of our potent inhaled anesthetics can trigger malignant hyperthermia: DES, SIVO, and ISO. Lastly, nitrous oxide, just a couple things about the physiologic effects of it. Although we don't usually think of it as a volatile anesthetic, it is one of our gaseous delivered anesthetics. So let's just briefly touch on that. Nitrous oxide actually stimulates the sympathetic nervous system and can increase pulmonary vascular resistance, such that we often avoid nitrous oxide in patients with pulmonary hypertension because it increases vascular resistance of the pulmonary system. Much less effects on the respiratory system, at least it appears to, than the volatile anesthetics DES, SIVO, and ISO. In the central nervous system, it too can increase cerebral blood flow and may produce a mild elevation in intracranial pressure. It doesn't significantly relax muscles and doesn't trigger malignant hyperthermia. One of the things that has decreased the use of nitrous oxide is the potential side effect of increasing postoperative nausea and vomiting, maybe more in adults than in children. So in summary, the physiologic effects of volatile anesthetics are shown here in that if we look at the brain, it vasodilates the blood vessels, increasing cerebral blood flow, but reduces the cerebral metabolic rate for oxygen, and under some circumstances can increase intracranial pressure. The heart, usually it preserves cardiac output with vasodilation, decreasing blood pressure with a reflex increase in heart rate. In the respiratory system, we pant under a volatile anesthetic with a high respiratory rate, low tidal volume, and CO2 tends to go up for several reasons. One, the blunting of the CO2 response, and two, the increase in VD over VT, or dead space, relative to tidal volume. And the apneic threshold that is defined as the highest arterial carbon dioxide tension at which a subject remains apneic is increased. And the example of that is If you have someone breathing through an LMA with an end-tidal CO2 of 50, and you say, I don't want an end-tidal CO2 of 50, I want the end-tidal CO2 to be 35, and you take over ventilation for them, breathe them down to 35, and they stop breathing voluntarily until their CO2 rises back up, their end-tidal CO2, into that 50 range. The apneic threshold has been increased in that patient breathing a volatile anesthetic. All volatile anesthetics are bronchodilators. They relax muscle, and they can cause malignant hyperthermia. So if we look at the ABA keywords again and go back and review the central nervous system, isoflurane would reduce cerebral metabolic rate for oxygen. The CNS effects of isoflurane would be an increase in cerebral blood flow, a decrease in cerebral metabolism. The SSEP monitoring effects of volatile anesthetics would be an increase in latency and a decrease in amplitude, with SSEP signals being affected less than motor evoked potentials, which are greatly affected by volatile anesthetics. In the cardiovascular system, desflurane, we know when rapid concentration changes are made, desflurane concentration is increased, that norepinephrine levels go up, heart rate can go up, and blood pressure can go up, stimulating the sympathetic nervous system, but this is blunted or attenuated by opioids, beta agonists, beta antagonists, that is, beta blockers, and drugs like dexmedetomidine. The volatile anesthetics are bronchodilators. They impair the ventilatory response to hypoxia even at very low concentrations. They increase the apneic threshold and blunt HPV, or hypoxic pulmonary vasoconstriction. And lastly, they are relaxers of skeletal muscle and potentiate neuromuscular blockade, both depolarizing and non-depolarizing. This ends the short foundational review of the physiologic effects of volatile anesthetics. I hope you have a great day and never stop learning.